It's February 21st, 2025. This is the Room Now podcast, and I'm Dr. Jack Cush, executive editor with RoomNow.com. This week on the podcast, we're talking manpower, we're talking AI, we're talking ILD, cancer risk, all the good stuff, and we're going to end it with lupus therapies. So the National Residency Matching Program published its 2025 results. I think we previewed that previously. We mentioned how well adult rheumatology match went, where of the 132 programs that we have, only 3 of them went unfilled. And I think that, the numbers are up on the number of fellows that we're training. I think it's up to around 250 a year right now. And that's encouraging. I don't think it's going to meet the gap we have with the growing need for musculoskeletal services. On the other hand, pediatric rheumatology, not so well. We have a major issue here. There were 36 programs that had open spots. Only 20 of the 36 went unfilled. Only 16 of the 36 filled. We've got a major issue. We need a major effort. We need to incentivize people to go into pediatric rheumatology. I went into rheumatology largely because of my interest in pediatric rheumatology. And for a while there, I was kind of confused about whether I was going to be a pediatric rheumatologist or an adult. I just happened to be an adult who's done a lot of pediatric rheumatology, which, by the way, the historical figures in rheumatology, John Baum, Jane Schaller, a whole bunch, have exactly that path. They were internists who did pediatric rheumatology. Some other stats: the pediatric rheum program was number 5th in the overall rankings with the number of osteopathic graduates. That was interesting at 30%. And the adult rheumatology match, rheumatology had the 5th largest number of international medical school graduates. So that's maybe how we're going to meet some of the manpower shortages by going with DOs and foreign grads. And I think that's a great idea. Lenny Calabrese, world-renowned DO rheumatologist. Jack Cush, wishing he were as good as Lenny Calabrese, a foreign grad from St. George's University. Lupus. I found an interesting. Actually, I saw it first on the Cleveland Clinic news site where they referenced this TULIP extension trial. TULIP was a study of lupus patients and the use of anifrolumab or placebo in people on background standards of care. Usually it's mycophenolate, hydroxychloroquine, prednisone. They showed you the 208-week results of 354 patients on anifrolumab versus 561 on standard care alone, showing that anifrolumab, those that were randomized anifrolumab, had about a 60% lower risk of organ damage as measured by the SLE damage index, or the SDI. That was compared to those who were first enrolled to standard of care. So, example here of aggressive treatment has significant downstream effects. This is 4 years later that these people had less overall damage index by the SDI. I think that's encouraging. The question that often comes up: lupus patients who go into renal failure, does their lupus get quiescent? Does it go away? Does it go away when they're on dialysis? What happens when they get a transplant? Well, a meta-analysis of 34 studies looked at this. 29 that were on either renal replacement therapy and 5 that were post-renal transplant. They found overall that extra renal flares were seen in 36% of patients with end-stage renal disease, as measured by the CKD stages. And it was higher, actually, in those that were on peritoneal dialysis or hemodialysis compared to those who had renal transplant. It was actually 4.3-fold higher. And it makes sense. If you get a kidney transplant, you get back your renal function, and you're going to do better. If you're on dialysis, you don't get back your renal function, you're replacing it, and then there are sort of pro-inflammatory or extra renal manifestations that go along with hemodialysis. So it's obviously better to get a renal transplant if that's possible. What's the recurrence rate of lupus nephritis in those who receive renal transplant? 3 to 4%. That's a good low number. So the idea that they go into renal failure and their lupus stops is not really true. It's not been borne out by my experience over many years and by many studies that actually have looked at this, although that's often sort of the folklore that gets passed around. A lot going on in the lupus world. We're going to talk about obinutuzumab as the last report today, but I wanted to review with you that there are 3 B-cell depleting therapies that target anti-CD20 as their mechanism. Rituximab was approved in 1997 and has since been approved for use in RA, GPA, CLL, and non-Hodgkin's lymphoma, as also for pemphigus vulgaris. I did not know that. Ofatumumab, which has been studied in lupus and other autoimmune diseases, was approved in 2020 for relapsing multiple sclerosis, and that remains its only indication at this point. The newer one that to us rheumatologists is obinutuzumab. That was approved in 2013 for follicular lymphoma, and then 2016, I think, for CLL. It's a very popular drug amongst our hematologist oncologist colleagues. It has replaced the use of rituximab across the board. I think head-to-head studies and anti-rituximab antibody issues are much better with this therapy. And right now, I just put up another report showing that ofatumumab and obinutuzumab are better than rituximab in the management of membranous glomerulonephritis of multiple etiologies, mainly because there's less anti-rituximab antibody secondary phenomenon that gets in the way of future efficacy, if not toxicity. So there are 3 out there. Only one is approved for use in rheumatology. That's only for RA and GPA. None are approved for use in lupus. Yet many of you are using rituximab in lupus. I don't. I won't. I'll use it for ITP and refractory thrombocytopenia or autoimmune hemolytic anemia, but not for renal manifestations because it's been shown to not work. You can yell at me about the design of the trials and whatnot, but the good news is we're going to see more in this area. Give me a few minutes. I'll get to that at the last report. A Korean's claim database analysis looked at the risk of renal cancer in RA patients. Don't know why they were doing this. They compared risk of renal cancer, I assume by this they mean hypernephroma, versus the general population. They showed that it was, in fact, increased 34%, and that was significant. And that this increased risk of renal cancer was unrelated to being seropositive or seronegative. It was somewhat higher in women with a hazard ratio, adjusted hazard ratio of 1.57 compared to 1.34. But RA was not associated with other urological cancers, including bladder, prostate, or testicular. And I think that's been shown in other studies. Another study on cancer in RA was done in Australia, where they compared 14,000 RA patients. Average age was 65 years with 33,000 controls. And they showed that pre-existing cancer in RA was less prevalent than the population, 7% versus 14%. But that new onset cancer, incident cancer in RA patients was actually lower in this study compared to the general population. The CIR, the cancer incidence rate, was 19.7 versus 24.8. And that cancer rate did not change over a 3-decade period. Most other studies have shown RA cancer risk to be equal to the general population with SIRs of 1, basically, or equivalent. But it's really misleading because some are elevated, like lung, leukemia, lymphoma, and skin, and some are decreased, like breast, colon, and whatnot. In this study, they showed that it was, in fact, lower compared to the general population, a little bit, not a tremendous amount, and it's been stable in Australia. But they did find that the cancer incidence rate was higher in RA for lung, previously reported, and hematologic cancers. By that, I assume they're meaning mostly lymphomas, but also some leukemias that's panned out in other studies. Again, I want to remind you, the rules here are RA patients with a solid tumor, treat them as if they have no tumor at all. That means breast, colon, prostate, testicular, tongue. Again, we can get into all kinds of arguments about melanoma and lymphoma, but if they have lung cancer, which is the most common cancer in RA patients, you treat them as you would treat them and let someone else treat their cancer. That's the way it's supposed to be. And that's in both guidelines from the ACR and EULAR. JAMA had a review this week on something we see related to cancer, and that's MGUS, monoclonal gammopathy of undetermined significance. And the interesting points of this review, a good review, if you want to look at it, is that the previous thought that MGUS was associated with osteoporosis and autoimmune disease is not likely to be true. So that's a reason not, or to actually do SPEP and M protein testing. MGUS, by definition, has no symptoms and has no organ damage. It's a benign condition that can be followed in the vast majority of people. Theoretically, you should only be doing M protein testing, or SPEPs, if there's a malignancy suspected, or if there is symptomatology and association with the monoclonal gammopathy. The risk of progression to malignancy from MGUS is low. I got a few reports on interstitial lung disease, still a hot button item here in rheumatology. Korean National Health Insurance data, 50,000 RA versus 261,000 controls, followed for 4 years. ILD was seen in 3.7% of RA patients versus 0.5% of controls. That's an 8-fold increased risk, hazard ratio of 7.84. It was higher in seropositive RAs, hazard ratio of 9, compared to seronegatives, hazard ratio of 4.8. So ILD is a low frequency event. Most studies in RA, in seropositive RAs, have shown around 8 to 10%. This study, looking at all comers, shows it's only about 3%. Is that what I just said? With 3.7%. So a Japanese study of 781 RA patients showed that about 10% of them developed ILD, and almost all of those, or most of those, were with the UIP pattern, which is expected, compared to the other autoimmune diseases that we see, scleroderma, lupus, myositis, where it's NSIP, right? Mortality is higher when you have RA compared to general population, 16% higher. But if you're RA-ILD, it's even higher than that. It's double that rate with a standard mortality ratio of 2.09. Again, the risk factors for mortality in RA were ILD, 3-fold increased risk, advanced age, 8% increased risk, and a low BMI, another 3-fold increased risk. Obesity, we think, is a big problem. Being emaciated is a much bigger problem. So think about that. The prevalence of ILD and systemic sclerosis in a Chinese study of 239 systemic sclerosis patients followed 8 years was basically 50%, 49.8. That amongst the SSILDs, 2/3 of them had progressive disease with elevated CRP as the predictor. These people have a high mortality rate. The mortality rate overall was 24%, with the main cause of death being pneumonia. Predictors were age, smoking, and high CRP for progressive disease with ILD. The rapid progressors, we talked about them before, and the high risk of death in those people. A survey of rheumatologists worldwide, mostly pediatric rheumatologists, 144, 2/3 of them pediatric rheumatologists, about their use of steroids in FAPA syndrome, also known as Marshall syndrome. This is one of those autoinflammatory syndromes with lymphadenopathy and fevers and a bunch of other features. Most of them prefer steroids, 92%. 42% expect a steroid response within 12 hours. It's kind of spread out after that. 31% use steroids routinely in these people. And a literature search on this issue shows prednisone is the most preferred steroid being used at 48%. Again, response rates are really high. This is an autoinflammatory syndrome, one, that does not have a genetic association that's known. 2, that does not, you don't run right into it with anakinra or other biologics. Steroids are the preferred drug of choice, although other biologics, including anakinra, can be used. My last 3 reports, I think, were interesting ones, targeting the programmed cell death protein receptor PD-1 has been used as a target for chemotherapy or immunotherapy in cancer. But we know that this is an activated marker on activated cells, and we now have monoclonal antibodies, rosnilimab, It's being developed for use in moderate to severe RA. This is the results of the Renoir, Renoir study, a 6-month trial where 424 moderate to severe RA patients either on or on background conventional DMARDs, and 60% had previously received a biologic or targeted synthetic. They were randomized to either placebo or one of 3 doses of rosnilimab, either 100 or 400 given every 4 weeks or 600 given every 2 weeks. The primary endpoint was a DAS-CRP at week 12, and then week 14 was also important. They also looked at CDAIs. Bottom line, at week 12 and at 14, pretty much all of these measures were significantly higher for pretty much all the doses. DAS-CRP was significantly dropped. The CDAI, less than 10, was achieved in 46%, 50%, and 38% on the 600 milligram versus 31% on the placebo. And then the ACR20 was 69%, 70%, and 75% versus a 53% placebo response. Note, if you will, the placebo response is 53%. What does that tell you? That's a high placebo response. And yeah, you need a delta treatment effect of more than 20% to be significant, and they achieve that here. Why do they have a 53% placebo response? This is probably a worldwide trial. We've discussed that in reviewing ACR data and EULAR data, that placebo response rates are highest in countries that are the poorest. And right now, there is less studies being done in North America and more studies being done worldwide, especially in poor countries, and you see high placebo response rates. That gets in the way of interpretation, but in this study, it looks encouraging. By the way, this data, which is, I guess, an phase 2B, I think it's a phase 2B study, yes it is a follow-up of an earlier phase 2. I think it was reported by Paul Emery. I think showed modest results. I think this is more encouraging, and I think means that this drug is going to go forward in drug development, would be my guess, because that was not discussed. The American Medical Association published the results of a U.S. physician survey in 2024. They just completed that. Well, they also did in 2023, and it looks at physician attitudes regarding artificial intelligence. And generally, it looks like you're starting to accept this. While there are many of you, 30, 40% of you are like, I don't know, man, that AI stuff looks goofy to me. Looks like someone's cheating, not reliable, whatever you want to say, it's not good. More are encouraged. So that the number of physicians, not rheumatologists, physicians, who say that there is some advantage to patient care is now 68%, up from 63% in 2023. That there's been substantial growth of AI in practices, that it's nearly doubled. In 2024, it's 66%. In 2023, it was only 38%. There's been a dramatic drop in those who said, I'm an AI non-user, count me out. It was 62% a year ago. It's now only 33%. And that's just in 1 year. It's very fast as far as healthcare technology adoption. And then, again, the greatest growth has been in the use of AI for documentation, discharge summaries, care plans, planning research, and standard of care summaries. If you're not doing it, look into Claude, look into ChatGPT-4, look into Gemini, find one you like and use it. I do. And I think it's important. Lastly, obinutuzumab, the anti-CD20 monoclonal antibody, has been studied in a phase 3 trial in patients with active lupus nephritis. It is a humanized antibody, previously approved for follicular lymphoma and CLL. This is a phase 2 trial of 277 biopsy-proven lupus nephritis patients who either got placebo or 1 or 2 doses of obinutuzumab, and they were followed out for a year. Actually, the results they're reading here in this New England Journal article was at week 76. So 135 received obinutuzumab, 136 placebo. The primary endpoint was a complete renal response, along with a few other things, complete renal response being a UPCR of less than 0.5 with a GFR of at least 85, no other problems, no other flares, no death, whatever. Again, the primary endpoint was achieved in 46% with the CD20 monoclonal and 33% With the placebo, that's a p-value of 0.02. More people on the anti-CD20 were able to get their prednisone down and tapered per protocol, 43% versus 31% on placebo. And UPCR of less than 0.8 was also more common with obinutuzumab at 56% versus 42% with placebo. Again, this is going forward. I would hope that we see this anti-CD20 monoclonal ultimately do well in a phase 3 and hopefully get approved for use in lupus. That's it for the podcast. Look for a number of the things we're going to put up. We're going to put up a few step talks. These are like TED Talks. One's on the website right now. Artie Kavanaugh talking about RA and liver disease. You'll want to check that out. And you're going to look at mine in the next week or so on RA flares. Is it a crisis or is it an opportunity? Check it out on the website. Take care of yourselves. Bye-bye.